Thank you. I will speak about the role of percutaneous valve therapy in patients with heart failure and severe aortic stenosis. So what we have witnessed over the years, and I use here the slide from Nakomo in the Mayo Clinics, is that when the population ages, as you see here on the x-axis, that on the y-axis there is a sharp increase in outcome, a sharp increase in mortality. And we see that there is a big increase in aortic valve disease with the ages, there is a big increase in mitral valve, and we put that together, there is a huge increase in the elderly degenerative disease, aortic stenosis and mitral regurgitation. The high-risk patients for valvular surgery, we've learned from the Euro Heart Survey, are the ones at older age that have a depressed ejection fraction, so there it comes for the first time, have heart failure, and have substantive comorbidities. So if we look at this Euro Heart Survey that was done quite some years ago, not undergoing surgery, 49% of moderate severe mitral regurgitation and 30% of severe aortic stenosis. And that has actually prompted our huge interest in these percutaneous approaches. These are the two ones and that are most used at the moment, the balloon expandable and the self-expandable. We've witnessed already several generations of those, each time improving, significantly actually reducing aortic regurgitation, paravalvular leakage. This was, I think, the first large trial showing the evidence that if you have in blue curve percutaneous aortic valve and in yellow curve medical standard therapy, that there is a big difference in mortality. So these are sick patients, because the first partner trial was in the very sick patients with a high risk, and they compared standard therapy, medical versus percutaneous valve, and there was a much better outcome with the percutaneous valve. Then also in that same study they compared surgery in yellow with percutaneous valve in blue, and they saw that those two, even in these very sick patients, had the same outcome, slowly building the case for percutaneous aortic valve replacement. You are probably aware that at ACC coming soon there will be the presentation of the Partner 2 trial. The Partner 2 is focusing one step further. It doesn't look at the severe sick patients, it goes now to the intermediate risk patients. And probably you're also aware that last week it was announced that the Partner 3 trial will be started shortly, and this will focus at the very low risk patients. So that means that we're witnessing going from severe risk to intermediate risk, which will be shown at ACC and probably is going to be non-inferior to surgery, now to very low risk. So gradually this therapy is becoming quite a reality. The next bridge that we're going to look at is percutaneous valve therapy in heart failure. So what I'm going to discuss with you briefly is, do we see that often heart failure in surgical and percutaneous? How to diagnose severe aortic stenosis in heart failure, because that is the most difficult part. What is the prognosis at the data that we have at the moment after percutaneous aortic valve? Is there an improvement or recovery of function after percutaneous aortic valve? And how can we better risk stratify the patients? Do we look at contractile reserve or do we look at MRI? So if we start with the prevalence of heart failure in surgical on the left and percutaneous on the right, it depends how you define heart failure. If you define heart failure by an ejection fraction of less than 40 or 50%, you see on the left in surgical patients that is around 20 to 30% of the patients. If we define it as an EF of less than 30 or less than 20%, you see on the right, this is percutaneous aortic valves, that it's around 10%, maybe a little bit more. So grosso modo, I think we can say that we're looking at about 20 to 30% depending on the ejection fraction that you're going to take as a cutoff point. But there is a significant amount of patients that have heart failure, reduced ejection fraction, and aortic stenosis. So how do we actually define aortic stenosis? Severe aortic stenosis depends on various criteria. I summarized them for you quickly here. We look at the jet velocity, which should be more than 4 meters per second. We look at the gradient over the valve, which should be more than 40 to 50 millimeters mercury. We look at the aortic valve area, that should be less than 1.0 centimeters square. And we look at the valve area indexed for body surface area, because a tall individual has a difference than a small individual. So the numbers to remember are gradient 40 to 50, aortic valve area 1, indexed area 0.6. If you keep these in mind, then we can move to the actual discussion. So first, as we speak about the gradients, just to remind you that this is the flow through the aortic valve that we're taking, and the max gradient is simply calculated as 4 times the maximum velocity over the valve square. Just to relate to you the gradients on the left to the valve area on the right, you see with the increasing gradients going from 2 to 16, 25, 45, 70, and 100, you see that the area quickly decreases from 3 to 1 to 0.6 to 0.5. Here we're talking about valve area and not indexed for body surface. Okay, so now the way we do this with echo, and this is an important slide here, is how we put together all this. So we take from the LVOT is what we measure here. And here is this velocity max through the aortic valve, and here is the velocity in the LVOT. And that we plot in this equation with echocardiography. So here is the LVOT surface area, here is the VTI LVOT, and here is the VTI over the aortic valve. And the critical point in this whole equation is here, because this part has the biggest impact on the severity of aortic stenosis, and it's immediately the weakest part in our echo. Because if you just make a little mistake here, you do 4 times PR square, you can make a significant change in your severity of aortic stenosis. So what could be a potential solution for this? In all the patients that are being referred for percutaneous valve therapy, you do an echo, where we get these velocities, which are easy to take. But we also do a CT scan, because we want to see the periphery arteries, we want to see the valve, we want to see the root. That is available in every patient. And so I thought, if we take the simple echo information and fuse it with the tracing of the LVOT, rather than doing the 4-point PR square, we have a much better estimation, actually direct visualization of this LVOT. So this is not fusing the two modalities, but it's fusing the information of the two modalities. I give you an example how that works. Here is the LVOT taken from the echo, and here is the surface area as we take it from the CT. And now if we would take the equation from the echo information, you would end up here with a echo valve area indexed of 0.58. This is a severe stenosis. If I now replace this echo LVOT by the CT LVOT directly traced, you see that the stenosis severity is now 0.79, which is not a severe stenosis. So this is the first case I make, that probably now that we have this new technology, probably some information we better take from the CT to come to more accurate diagnosis of aortic stenosis severity. This is in the routine patients. So far we did not speak about the heart failure patients. So this is just artifacts based on the difficulty that we have of measuring LVOT. We can also analyze direct planimetry. We can just measure the opening on an MRI, and we can also trace it on a CT scan. And if we compare that with routine transesophageal echocardiography, for example, MRI versus TEE, we see that we have a very good correlation. Here is the tracings done, and here is the tracings done. Now let's move to the population that we're talking about. The difficult situation, aortic stenosis, heart failure, how to diagnose. The situation is, because of the heart failure, we have a low flow over the aortic valve, which results in low gradients. So the aortic valve area shows severe stenosis, but the gradient, due to the low flow, shows no stenosis. And how do we work with that in the practice? I illustrate that to you in two cases. Here's the first case. It's a 73-year-old man. He had an infralateral infarction in 2003. He has in 2006 angina. He has an ejection fraction of 20%. We do an angiogram. He has 3-vessel disease. He gets a bypass surgery and ICD. The current symptoms are progressive dyspnea. He has significant comorbidity. He has kidney disease, and his logistic Euro score here is extremely high. Usually if we talk about over 20%, it's a high logistic Euro score. So he has a high score. He's at high risk. Here we see his echo. You see the infarcted area. You see very poor function. You also see that the valve is not opening well. You see that due to the turbulence here that there is a gradient. We see the velocity max. So there is aortic stenosis. The EF, as we calculate, is 40%. The effective valve area is less than 1, so severe stenosis. But the gradient is less than 30 to 40. And I indicated to you in the beginning, think about valve area, think about velocity, and think about gradient. This gradient shows no severe stenosis. This valve area shows yes, severe stenosis. And this is the situations that we're going to encounter when we do discuss about aortic stenosis and heart failure. So the question is really, is it the valve that is not opening, and is there a stenosis? Or is it the ventricle that's not functioning? If the ventricle doesn't function, the valve doesn't open. So what do we do to better define that? Again, 35% of the patients with severe aortic stenosis have a low EF, have a low flow therefore, but also have a low gradient. So what we do is we follow this algorithm here. The top part shows us the problem. We have a valve area less than 1 or an indexed area less than 0.6, indicating severe stenosis. We have a mean gradient, however, of less than 40, indicating no severe stenosis. And we have the heart failure. So this is what we call the classical low flow, low gradient aortic stenosis. And what we do is here in the middle is we do a dobutamine challenge. We give 20 micrograms of dobutamine, and we have two scenarios, and I'm going to illustrate that in two cases. What we can see, because the low-dose dobutamine is going to increase the contractility of the heart. If then the valve area becomes more and the gradient remains less than 40, this is not the severe stenosis. This is the heart that is not functioning. And if we, with the dobutamine, increase the heart function, we start to open the door, which is the valve. And that is what you see here, the valve area gets bigger. So this is a pseudo-severe stenosis. If we have, however, that we see that the valve area remains low, but we increase the gradient, then the door isn't opening. The door is diseased. We're increasing the function, the blood wants to go out, but the door doesn't open. Very simple as that. Valve area remains low, gradient increases. This is a true severe aortic stenosis. Sometimes we get in trouble, as we see here, that the aortic valve area doesn't change and the gradient doesn't do much either. Then we have a rescue technique. We have a CT scan. And the CT scan that we already have shows us lots and lots and lots of calcium. Then this must be a stenosis. If the CT scan shows almost nothing, it's very hard to believe that that is a stenosis. So these are the three scenarios that we can use. Now let's go back to the case. So we do a dobutamine stress echo as an alternative, or as an escape. As I showed you, we can do CT scan. So here is our case again. If this would move, we see the baseline, we see the dobutamine, we see the increase in contractility. The mean gradient is 20, but the area says, oi, there's severe stenosis. This says no stenosis, this says yes stenosis. And now with the increase in contractility, we see that the gradient picks up. So it is the muscle that is increasing in contractility, and therefore the gradient improves. For your convenience, I put the CT scan as well, and you see that there is a lot of calcium. So this confirms severe aortic stenosis. This actually puts us in the scenario here. The low-dose dobutamine, the valve area remained small, the gradient increased, so both of them direct you to severe aortic stenosis. So this is a true severe aortic stenosis. And as additional evidence, you have the CT scan, which shows all the calcium. Now we take a second case. This is a 57-year-old female, atrial fibrillation, has successful ablation in 2004, then is on and off atrial fibrillation. Coronary disease, she's obese, she has breast cancer in 1984. So she has surgery, chemo, and radiotherapy. Her current symptoms are dyspnea and persistent, every now and then on and off atrial fibrillation. Here's the EKG. You see the atrial fibrillation with rapid episodes following of ventricular contraction. Here you see the echo. I have a reduced ejection fraction. I have a not so well opening valve. There seems to be some gradient. So we measure. The gradient is 14, very low actually. But the area says, this is less than 0.6 body surface area. So that is a severe stenosis. This one says severe stenosis, this one says no stenosis. So we need to do the trick again with the dobutamine. Here is the baseline, here is the dobutamine. You see how significantly the contractility is doing something. So what do we measure? I put it here for you, baseline, gradient 14, index area 0.5, so severe stenosis. What happens with the dobutamine? The gradient increases a little bit, but not significant, remains low, and the area starts to increase. Or another way, we increase the muscle, starts to pump better, and we open the door. That is the simple trick. For your convenience, we don't need it, but I put it here, the CT scan. You see little calcium, and you see also here on the valve not much calcium. This is therefore the following scenario, the pseudo-severe stenosis. So what you use in this diagnosis is a dobutamine stress echo, low dose, plus a calcium scan if needed. What about if we start doing this heart valve surgery with percutaneous approaches in patients with reduced ejection fraction? This comes also from the partner trial, and you see here low flow severe aortic stenosis. That are the cases that we just spoke about. We see that if we treat them with a percutaneous valve, that the death is high, but much lower than if we treat them conservatively. So there is some evidence that this is doing something good for the patient. Let's look here at the bottom. At the bottom you see in blue the percutaneous aortic valve ejection fraction changes in a starting EF less than 50%. So this here is the starting EF, and you see after you change the valve, either surgical in orange or percutaneous in blue, that you significantly increase the ejection fraction. So we have a better survival and we bring back LV function. In addition to better survival and better ejection fraction, we can use the contractile reserve also for predicting what's going to happen. And we see that if there is contractile reserve If the muscle is still okay, it is dysfunctional, but I give a challenge and I see that it still picks up. There must be good substrate in that muscle. That muscle is not fibrosed completely and cannot do anything. No, if you do a positive challenge, and these are the patients with valve replacement and the contractile reserve that do very well, indicating if we have contractile reserve, if we replace the valve, it's probably associated with the best outcome. We also have this new technique, which is MRI, where we can see with techniques fibrosis, such as here in the wall. This is this whitish tissue, and also here. What does the fibrosis probably tell us? The fibrosis tells us there is a stenosis. The heart has to work all the time harder than normal. The muscle has to do more than normal. How is it reacting? It's reacting with replacement fibrosis. So if you see fibrosis and it becomes much, the likelihood that you do something good for that patient with whatever surgery or percutaneous valve is not so high, because there is a point that the muscle will be too much damaged. And that's why I put in the previous slide that if there is still contractile reserve, there's probably still enough alive, good functioning myocytes there. And that is the momentum between those two to pick your pick and go for the percutaneous valve or the surgical valve. So why are patients not referred for surgery again? Low EF is a very important player. 50% of the aortic stenosis in this cohort are not being referred for surgery. So there is a niche for percutaneous aortic valve. And that's the study that we're going to do. This comes from the partner trial cohort. This will be done partially in Europe and mostly in the United States. So treat before the LV is too damaged. This is called the TAVR unload. We're starting it soon. We will have a sub-study in that where we're comparing the CT and the echo to better phenotype the patients. And we're going to use moderate aortic stenosis, so not that severe aortic stenosis. Why? Because we believe if we take the moderate aortic stenosis that we're probably catching the patients when there is not yet too much damage in the ventricle. And what we're going to look at to see if we do percutaneous valve in these patients versus medical therapy, whether we will improve the outcome. And the hypothesis is, if there is stenosis, but not that severe, the muscle is still okay, and we can do actually the replacement, and the outcome will be better. Thank you very much.